Hello, and welcome to this installment of the COVID-19 What Pharmacists Know Now series, brought to you by the Canadian Society of Hospital Pharmacists, BC branch. My name is Tanveer Brar, and I am a clinical pharmacy specialist in critical care at Surrey Memorial Hospital in British Columbia. Today's presentation focuses on the use of Sotrovimab for the early treatment of COVID-19. I have no current or past relationships with commercial entities, and the views in this presentation are my own and do not reflect those of CSHP-BC. The devastating spread of the COVID-19 pandemic has stimulated an accelerated program of research to try and identify effective ways to limit the spread of infection and to reduce the morbidity and mortality associated with COVID-19. As a result, the data pertaining to COVID-19 therapies are rapidly changing, and the information presented here is based on the best available evidence as of December 27, 2021. In this presentation, we will discuss the role of monoclonal antibodies in the management of COVID-19, as well as the available evidence for the use of Sotrovimab in mild COVID-19 disease and briefly in moderate to severe COVID-19 disease, and the patient eligibility criteria for Sotrovimab therapy. Understanding the structure of the virus and its behavior can help us understand the targeted therapies. So starting with the structure of the virus itself, there are four important structural proteins, and most important is the spike protein. The spike protein is the major glycoprotein that extends from the surface of the virus, and it's what gives coronaviruses their unique appearance. It is also important because it is the attachment and fusion protein. So once the virus is transmitted into the host, the first step is attachment to the host ACE2 receptors, which are found predominantly on type 2 alveolar cells, intestinal epithelium, and vascular endothelium, as well as other places. The virus then penetrates into the cell via membrane fusion events and is taken up by endocytosis. It then uses the host's machinery to make structural proteins that are required to form new virions, which will then be packaged into vesicles and fused to the host membrane to be released. One infected host cell can create hundreds of new virions. SARS-CoV-2 can cause a broad spectrum of disease depending on which stage of illness the patient is in. Stage 1 is the viral response phase, where the virus is replicating at its peak, and patients will typically present with fever, cough, and other constitutional symptoms. Many patients will recover after this stage and often don't require hospitalization. Some patients will go on to stage 2, where an adaptive immune response starts to occur and there is a reduction in viral load. In this stage, there is an increase in inflammatory markers and respiratory involvement, which may require hospitalization. Unfortunately, some patients, usually those who are at high risk of disease, such as the elderly, immunocompromised, or comorbid, will progress to stage 3, which is the hyperinflammatory phase. Here, the pathophysiology appears mostly to be driven by a dysregulated host innate immune response. So, based on the progression of COVID-19 disease through those various stages, proposed therapies have then been targeted at the virus itself, shown here in blue, or at dampening the hyperinflammatory response that occurs, shown here in orange. There have been some proposed therapies that do a little bit of both. So based on the trajectory of illness and the two different pharmacological strategies for management of COVID-19, it then makes sense that treatment strategies should be based on the stage that the patient is presenting with. Pharmacotherapy that is targeted at the virus, so antivirals or monoclonal antibodies, may be useful earlier in the course of illnesses, but later in the stage of disease where the viral load has decreased, they may not be as beneficial. On the other hand, immunomodulatory therapies such as dexamethasone and anti-cytokine antibodies, if given too early, may not be necessary and may actually increase viral replication and inoculum size. But in stage 3 illness, where the goal is to dampen the hyperinflammatory response, they can be very beneficial. The neutralizing monoclonal antibody therapies that target SARS-CoV-2 have been considered promising potential therapies for COVID-19 since the beginning of the pandemic, and they've gained a lot of notoriety in recent months. They have been studied throughout all stages of infection, from mild to moderate therapy, and even for hospitalized patients. There are 3 anti-SARS-CoV-2 monoclonal antibody therapies that have current emergency use authorization by the U.S. Food and Drug Administration for the treatment of outpatients. And these are Sotrovimab, Bamlanivimab plus Etesevimab, and Casirivimab plus Imdevimab. So what are monoclonal antibodies? So, antibodies in general are Y-shaped molecules or proteins that are produced by our B cells, and they have this FC or constant region, which is the same for every single antibody in the body, and it's what's recognized by the host's immune system. They also have this variable region for which there are millions of variations, and this region is specific to different invading pathogens and specifically different epitopes on that pathogen. Monoclonal antibodies are clones of the same variable region that identify and neutralize a singular pathogen by targeting a very specific epitope on that pathogen. They differ from convalescent plasma, which consists of polyclonal antibodies in serum that are derived from previously infected patients. These proteins are derived from B cells of convalescent patients who have previously been infected or humanized mice that have been exposed to SARS-CoV-2 antigens. And these exogenous proteins serve as substitute antibodies to restore, enhance, or mimic the immune system's attack on the virus or pathogen. They're a form of passive immunity. And monoclonal antibodies are not a new concept. They've been investigated for a variety of other viruses and have been shown to be effective for RSV and Ebola in human trials. From the earlier slide, recall that in order to replicate, SARS-CoV-2 must first bind to the ACE2 receptors on the surface of human cells for cellular uptake. Monoclonal antibodies targeted at SARS-CoV-2 are designed to bind to and occupy the receptor binding domain of the spike protein. This prevents binding of the spike protein to its cognate ACE2 receptor on the target host cells, and therefore the virus cannot be taken into the cell and all the downstream effects of the viral replication cannot occur. So these anti-spike protein antibodies essentially neutralize the virus. Additionally, once the antibody binds to an antigen, that constant or FC region is identified by the host's immune cells, which will then result in the antigen-antibody complex being engulfed and cleared. So they have a bit of a bouncer effect. Not only do they prevent the virus from getting into the cell, but they will also call for backup to have it removed from the host entirely. Sotrovimab, also known as VIR-7831 in earlier studies, is a human monoclonal antibody that was actually derived from a SARS-CoV-1 survivor. The variable region of sotrovimab binds tightly to a highly conserved epitope of the SARS-CoV and SARS-CoV-2 spike protein, which is shown in orange. And this region is outside the highly mutagenic ACE2 receptor binding motif, shown in green. Sotrovimab actually does not compete with human ACE2 receptor binding, but it inhibits an undefined step that occurs after viral attachment, but before fusion of the virus to the cell membrane. The highly conserved epitope has been found on 99.8% of other cervicoviruses, which allows sotrovimab to retain its activity against those as well as variants of concern. It has an emergency use authorization issued in May 2021. Additionally, sotrovimab has two modifications in its constant region domain, which are designed to increase lung penetration and half-life while maintaining its effector function. The efficacy of sotrovimab in patients with early mild COVID-19 disease was studied by the COMET-ICE investigators. The interim data were published in the New England Journal of Medicine on October 27, 2021, and the final data were pre-published on November 8, 2021. And this was a multi-center study looking at patients from 37 sites across Brazil, United States, Canada, and Spain from August 2020 to March 2021. It was randomized, double-blind, and placebo-controlled. They enrolled adult patients with a positive SARS-CoV-2 test and an onset of COVID-19 symptoms within the previous 5 days and high risk of progression to severe disease. High risk of progression to severe disease was defined as age greater than or equal to 55 years or one of the following risk factors: diabetes on medications, obesity, chronic kidney disease, congestive heart failure, COPD, or moderate to severe asthma. They excluded patients who already had severe COVID-19 disease, defined as shortness of breath at rest, oxygen saturations of less than 94%, or use of supplemental oxygen. Their intervention was sotrovimab 500 milligrams IV given once, and they had 291 patients that were included in the interim analysis compared to placebo, which had 292 patients in the interim analysis. Their primary outcome was hospitalization for more than 24 hours or all-cause mortality through day 29 after randomization. Their secondary endpoints included emergency department visits, hospitalization or death, disease progression that warranted the use of supplemental oxygen, or adverse effects. Note, this study was sponsored by the manufacturer of Sotrovimab. Looking at the patient characteristics of patients enrolled in this study, the median age was 53 years, about half of the patients were male, and the majority of them were white. The BMI average was 32 kilograms per meter square, and about 57 to 59% of patients were within their first 3 days of symptom onset. When we look at the singular risk factors for COVID-19 progression, about 46 to 48% were greater than 55 years of age, and about 63% of patients were obese with a BMI of greater than 30 kilograms per meter square. When we look at their primary outcome, which is the composite endpoint of hospitalization greater than 24 hours or death, 3 patients in the Sotrovimab group met this endpoint and 21 patients in the placebo group. And this was, of course, largely driven by hospitalization for any cause through day 29. And this resulted in a relative risk reduction of 85% and a statistically significant difference. Other clinical outcomes that they looked at included emergency department visits for any cause. So there were 2 patients in the Sotrovimab group and 8 in the placebo group. They also looked at severe or critical progression of disease. So 2 patients again in the Sotrovimab group and 19 in the placebo group. And this was largely driven by the need of supplemental oxygen via low-flow nasal cannula or face mask, which was both patients in the Sotrovimab group and 11 out of the 19 in the placebo group. Interestingly, no patients in the Sotrovimab group required admission to ICU for any cause or invasive mechanical ventilation, but 2 patients in the placebo group required invasive mechanical ventilation and 5 required admission to ICU for any cause. With respect to their safety outcomes, there was really no big difference in infusion-related reactions, any adverse effects, or any serious adverse effects between Sotrovimab and placebo. And interestingly, there were actually more adverse effects in the placebo group than in the treatment arm. So the bottom line from the COMET-ICE study was that in non-hospitalized adults with mild to moderate COVID-19, not requiring oxygen, at high risk of progression to severe disease, Sotrovimab reduced the need for hospitalization for more than 24 hours and death due to any cause by day 29 when compared to placebo. The final COMET-ICE trial results in the full trial population of 1,057 participants also demonstrated a 79% relative risk reduction, which was statistically significant in their primary endpoint as well. So the interim analysis results were consistent with the final results. So the US National Institute of Health, or the NIH, established the third Accelerating COVID-19 Therapeutic Interventions and Vaccine Platforms, or ACTIV platform, to rapidly test antiviral therapies among patients that are hospitalized with COVID-19. And this ACTIV platform is also an adaptive platform. And because the efficacy for anti-SARS-CoV-2 monoclonal antibody therapies for patients that are admitted to hospital with more severe disease has not really been established, and there are no trials to date that have reported results for patients that are hospitalized with COVID and treated with either Sotrovimab or a new monoclonal antibody combination of BRII-196 and BRII-198. This study that was published in Lancet a couple weeks ago aimed to do so. They tried to answer the question, what is the efficacy and safety of these 2 different monoclonal antibodies for adult patients that are hospitalized for COVID-19? So this was a multi-center study at 43 sites across the United States, Denmark, Poland, and Switzerland from December 2020 to March 2021. It was double-blind randomized controlled trial within that ACTIV platform. They enrolled adult patients greater than or equal to 18 years of age that were admitted to hospital for acute medical care for COVID-19 with a lab-confirmed SARS-CoV-2 infection and COVID-19 symptoms for up to 12 days. They had a long list of exclusion criteria, including patients that had received any SARS-CoV-2 neutralizing monoclonal antibodies, hyperimmune immunoglobulin to SARS-CoV-2, convalescent plasma from a person who had recovered from COVID-19 anytime prior to this hospitalization. Patients were also excluded if they required high flow oxygen, non-invasive ventilation, or invasive mechanical ventilation. But if they were requiring low flow oxygen or face mask, they were eligible for enrollment. And they also excluded patients that met any of the other criteria for acute organ failure or extrapulmonary manifestations of COVID-19 disease. So TICO facilitates the simultaneous testing of multiple agents. In this case, their intervention groups were the Sotrovimab and that new combination monoclonal antibody BRII-196 plus BRII-198, and it was compared to a common placebo group. Their primary outcome that they were looking at was the time to sustained clinical recovery up to day 90, defined as time between randomization and discharge from hospital for 14 days. They also looked at pulmonary ordinal and pulmonary plus ordinal outcome scales at day 5. Their secondary endpoints included all-cause mortality up to day 90 after randomization and time to discharge from index hospitalization, as well as some composite safety endpoint of all-cause death, serious adverse events, incident organ failure, and serious co-infection. Other treatments for COVID-19 in this population were up to the discretion of the treating physician as per their local standard of care guidelines. So when we look at some of their efficacy outcomes, the one that we care about the most was the sustained clinical recovery up to day 90 and death up to day 90. So with respect to sustained clinical recovery up to day 90, which was their primary clinical efficacy outcome, there were 160 patients that met this criteria in the Sotrovimab group, 151 in the placebo group, and 155 in the investigational monoclonal antibody group, and none of these results were statistically significant. Also looking at death up to day 90, 14 patients in the Sotrovimab group, 13 in the placebo group, and 15 in the investigational monoclonal antibody group, and really, again, no statistically significant difference. So the bottom line from the ACTIV-3 TICO study was that in adult patients that are hospitalized with COVID-19 and have symptoms for up to 12 days, treatment with either Sotrovimab or BRII-196 plus BRII-198 did not improve their day 5 pulmonary status, time to clinical recovery, or other clinical outcomes when compared to placebo. So really, time sensitivity is an important thing when administering monoclonal antibodies. However, there will be more data around this. The recovery group, which is another multi-arm adaptive clinical trial that looks at randomized evaluation of COVID-19 therapies, announced on December 23rd that they will also be investigating Sotrovimab as a possible treatment option for patients hospitalized with COVID-19. Recently, there have been many questions on how the efficacy of these various monoclonal antibodies holds up against the variants of concern. Recall that our previous MABs are targeted at the highly mutagenic ACE2 receptor binding domain, whereas Sotrovimab binds to a highly conserved non-receptor binding motif. And as a result, Sotrovimab is anticipated to be active against all major variants of concern that have been identified thus far, including the newest variant, Omicron. Unfortunately, bamlanivimab and etesevimab, as well as casirivimab and imidevimab, or RAIN-CoV-2, are unlikely to be active against the highly contagious Omicron variant. And given that this is the predominant circulating variant at this time, Sotrovimab should be the MAB of choice. And based on the current available data, the major COVID-19 guidelines have made the following recommendations that are listed here. So the IDSA group recommends that among ambulatory patients that have mild to moderate COVID-19 that are at high risk of progression to severe disease, Sotrovimab should be administered rather than no neutralizing antibody therapy. And this is a conditional recommendation based on moderate certainty of evidence. The NIH suggests that for non-hospitalized patients with mild to moderate COVID-19 who are at high risk of clinical progression, Sotrovimab is recommended, so long as they meet the emergency use authorization criteria. The World Health Organization has not yet made an updated recommendation for Sotrovimab. Their last update was on September 24th, 2021, where they were still recommending RAIN-CoV-2 at that time. Our local BC COVID Therapeutics Committee recommends Sotrovimab for mildly ill patients on a case-by-case basis in patients who meet the eligibility criteria and not for severely or critically ill patients. And there are still some special populations to consider that could still stand to benefit from Sotrovimab, but the therapy just hasn't been well studied in these populations. So there's children. So children were not studied, but the emergency use authorization for Sotrovimab does apply to children that are greater than or equal to 12 years of age and weigh at least 40 kilograms. Similarly, for pregnancy and breastfeeding, there is no data, and it should be administered on a case-by-case basis after a risk-benefit discussion. But the emergency use authorization that was provided by the FDA does include pregnancy as a risk factor, making patients eligible for administration of Sotrovimab. And finally, immunocompromised patients or those who are unlikely to respond to vaccination due to receiving either B cell depleting therapies or having conditions that affect their ability to mount an antibody response. So, such as those patients that have had bone marrow or solid organ transplants that are currently receiving immunosuppression, patients with a recent hematopoietic stem cell transplant in the last 2 years, patients with primary immunodeficiency, active treatment for hematological malignancies, or those that receive B cell depleting therapies within the past year. And these lists are very well defined and highlighted in the BC COVID Therapeutics Committee guidelines that kind of allude to which patients would be ideal for Sotrovimab therapy. So there are some practical considerations to keep in mind when using Sotrovimab. So monoclonal antibodies are difficult and costly to produce, so drug supply is limited. There are some areas of the United States that have completely run out of supply. And in addition to the supply itself being limited, resources are also limited. So Sotrovimab is infused intravenously over 30 minutes, followed by a 60-minute post-infusion monitoring period. So it is quite a bit of resources depending on how many patients are requiring the drug that day. However, this is being studied to be used intramuscularly in the COMET-PEAK trial, which is a phase 2 randomized multicenter parallel group study that is initiated by the manufacturer. And hopefully the results of that will be available in early 2022. And finally, patients should always be informed about that Sotrovimab does not have full Health Canada approval for this indication, and consent should always be obtained. With that, I would like to thank you so much for listening to this presentation, and I've included my email here if there are any further questions.